Okay, good morning, good afternoon, good evening, everyone. Welcome to the 81st episode of the Stop COVID Deaths webinar series brought to you by the University of the Philippines. Thank you for being part of our credible online community. At to all those po na for the very first time ay ngayon pa lang po kami na-discover, welcome po at sana po masayahan po kayo at marami po kayong matutunan sa ating online community. On November 26th of this year, the World Health Organization called for an urgent meeting. So last week lang po ito, no, to discuss the possibility of a new variant of concern dahil hindi pa po siya variant of concern noon based on genetic sequencing of the SARS-CoV-2 virus that had multiple mutations on the spike protein. This was first reported in Botswana and later allegedly responsible for a steep rise in cases in South Africa. Within a few days, the World Health Organization declared the new variant as a variant of concern and named it Omicron, further sparking tension around the world and warning against travel bans and closing of borders. So mapapansin nyo po, lalo na po sa mga balita, marami na po ang mga bansa talagang hindi po muna nagpapalipad o nagpapapunta ng mga travelers galing po sa mga selected po na mga bansa dahil na rin po sa banta ng Omicron variant. So does the emergence of this new variant affect the current clinical management of COVID-19? To get the latest information from the most credible sources, please stay tuned. I'm Dr. Raymond Francis Sarmiento, Director of the National Telehealth Center, National Institutes of Health, University of the Philippines, Manila. Always a pleasure to be with all of you during our regular Friday lunch date, and I always look forward to Fridays because I get to share hosting duties with a beloved mentor, also my partner, our adjunct research faculty at the National Telehealth Center, and the special envoy of the President for Global Health Initiatives, Dr. Susie Pineda Mercado. Dr. Susie?
Hi Raymond, good afternoon. Magandang hapon po sa inyong lahat. Saan man kayo naroon, we hope you're okay, you're doing well. We really what should I say, we're purposely going to change our format a little bit because of this new variant. But before we start, I would like to call for a moment of silence for one of our colleagues. Nag-guest po siya rito, si Dr. Raul Andutan. And you might remember him sometime back. We had him when we discussed the COVID variant. He passed away. And I'd just like to have a moment of silence for him. So let's just have a moment of silence. So thank you very much, everyone, for that pause. Talagang talagang mahirap, no, kasi pag merong pang nawawala sa atin, no, and in this case it was not a very what should I say, it was a very unexpected death. So nakiramay po tayo sa kanya, sa kanyang pamilya, sa mga mahal niya sa buhay, at naalala natin siya dahil somehow nakatulong din siya sa ating webinar. Okay, so thank you for that. And Raymond, we're going to parang nawala tuloy ako sa nawala ako sa bearing ko. Okay. We are going to have a brief discussion with all our panelists immediately. Kasi gusto nating pag-usapan kagad itong Omicron, no? Ano, Raymond, no? Parang magpa-panel discussion na tayo kagad. Do we have everybody here ready?
I think we do. Yes.
Okay, so can we ask all our panelists, please open their... Okay, and let me introduce our panelists one by one. No? Sabi natin, we'll talk about this right away because there's a strong interest in it, and we of course, one of our guests will talk about it in a little bit more of detail, but we wanted to open with a panel discussion because it's really a burning issue. Laman po ng lahat ng balita, and I'm sure you're all very curious about this. I noted this morning, I noted in our chat box, marami tayong mga nanonood from Mindanao, from Zamboanga, from from Ipil, from Coronadal, no? Ang dami nating mga kaibigan natin in Isabela and Bulacan. So from all over the country, we have doctors who are watching. So we thought we'd take this time to talk first about this variant, and then we'll go into the certain formal presentations later. So in our panel, we have Dr. Franco Felizarta. You know him, Felizarta. You've met him before. He's an infectious disease specialist practicing in the United States. Dr. Jubert Benedicto from the Philippine General Hospital. Dr. Maria Virginia Abalos or Jean Abalos from Cebu. Dr. Ted Herbosa from the National Task Force and has been working really day and night on vaccination. And Dr. Benny Atienza. So, okay, so let's get this rolling, Raymond. Let me ask you. So we wanted to make this a very informal conversation, and I encourage you to talk to each other as we do this very brief discussion. But the first question is, what was the first thing that came to your mind when you heard about this new variant that has been declared a variant of concern? So we'll start with Franco. Go ahead, Franco.
Well, I was looking at the mutations, and there were 50 mutations in the, that's a record. And in terms of divergence, it's the most divergent of all the variants. Not only that, out of the 50 mutations, 35 are in the spike protein, 15 in the receptor binding protein. And if you look at all the variants, it has all of the necessary irrelevant variants. So it's very concerning. And then, if you look at the spikes, if you look at this epidemic curve of South Africa now, it's already starting the surge. Now, the deaths is still stable, but we don't know. We have to wait for the hospitalization rates and the deaths, which will take about 1 to 2 weeks after. So, but it's very concerning, the increased transmissibility and the possibility that it will decrease the vaccine efficacy. So
okay.
Very concerned.
So you're going to talk a little bit more about that, Franco, but you felt very concerned when you first heard about this. Jubert, you're in the, what should I say, in the belly of PGH, handling critical care, no? Anong naisip mo? What was the first thing that came to your
The first thing that came to my mind was goodbye Christmas break. Kasi parang I was given, being one of the senior consultants that's in this since the pandemic last year, parang pinagbibigyan nila ako pag Christmas time na ako yung mag-off. Pero when I heard about the Omicron, parang nasabi ko nga goodbye Christmas break. And then I was really reading through the news, being updated in terms of implications sa management. So what we're doing right now is, kasi parang nag-shift na sa non-COVID mode, just like possibly other hospitals. So what we're doing right now is we're really having a good grasp ng aming inventory in terms of equipment. And then just right, I think last Monday, I was having a meeting with all my RTs and with all, of course, the fellows and consultants, telling them, ano ba yung kailangan natin para wag tayo maging reactive, just in case, there will be a surge and it will hit us. Ilan ba yung ating mga ventilator? Functional ba lahat? Ilan yung ating high flow machine? Functional ba lahat? O yung mga kailangan nating gamot? Make sure na ka-stock up sa pharmacy. So it was really more on that stage, Ma'am Susie. So pine-prepare ko yung sarili ko and then the others as well. Since we are, of course, sliding to the Christmas break, medyo syempre nandun sa holiday season yung utak din ng lahat, no? May nagki-Christmas party na kahit virtual. Pero ang point ko, we should be on our toes and just, ready to react appropriately.
Okay, so let's hear from Cebu, no? Dr. Jean Abalos, who's medical director of the Chong Hua Hospital in Cebu. What was your reaction, Jean?
Well, number one, I mentioned, kailan ba matatapos tong Greek alphabet na to? Two things came to my mind. Of course, number one, because as medical director, we have been doing a lot of meetings already. expecting really to have a surge, parang mas mabuti na kasi na ini-expect mo na magkaka-surge para hindi tayo nabibigla. Especially with what happened to us with the Delta, no? Talagang ang grabe yung pila dito sa Cebu and of course in PGH and everywhere. So just like what Jubert mentioned, we also have like a list of all the machines that we have. We even prepared protocols, no, for what we will do just in case talagang hindi makayanan na sa ER. So those things, no, the medical director staff, and of course as a practicing OB-GYN, I was thinking, ano na naman kaya ang mangyayari sa mga buntis namin? Because last year, we didn't really have much problems with our pregnant patients, very minimal complications. But this year, with the Delta, there is really a marked difference, which I like to share with you. So nagiging question ngayon sa atin, yung bang bakunado protected na? So, and I believe that this is something that is in the minds of everyone, especially as Dr. Franco mentioned na ang dami niyang mutations, no? So that's tough, no?
Okay, so let's move to Benny, Dr. Benny Atienza, President of the Philippine Medical Association. Benny, what was the first thing that came to your mind?
What came into my mind, kasi as a pediatrician, palagi kinuisip yung mga bata. May instinct na, how about yung mangyayari sa 11 to yung 11 below na wala tayong vaccine? And during the first surge of the COVID, hindi na maapektado yung mga bata. Then yung nagka-Delta, 10% of 18 below was affected with COVID. At saka different yung manifestation yung nag-COVID. I don't know bakit ganun, diarrhea lang. Tapos pag pina-x-ray mo, may pneumonia na yung bata. How about more kung sa Omicron to mangyari? And we don't have the vaccines pa for this less than 11 years old. Ngayon, napakalax na natin. Even in different media, social media, and television, I told them not to be complacent kasi wala pa silang bakuna. Punta sila ng mall. Even the toddlers are being brought to kasi lax na tayo yung ganun. And natatakot ako kasi baka mamaya yung mga vulnerable nating less than 4, kasi do sa less than 4 do sa 18 below, yung less than 4 years old, ang maraming naapektuhan ng COVID yung deaths. At saka how about yung vaccines natin, the equity, as said nga ng WHO, yung equity ng vaccines, yung lesser, yung mga lower economic countries, tapos ang nabibigyan ng vaccines, marami yung sa Europe and different areas. And according to the reports, ang naapektuhan daw mostly ng Omicron is yung mga universities, paano yung pagpasok na ating mga colleges, less than 40 daw. Parang simple lang yung ang symptoms nila, 2 days fatigue, headache, then makeup. Napakasimple na ng pagkakamala lang nating flu.
Yeah, thank you very much, Benny. No, another perspective, no? So parang from the point of view of kids. Okay, Ted Herbosa is here. Ted.
Yes.
Benny was talking about vaccines, and congratulations, first of all, on the tremendous feat that you guys have achieved in vaccinating. I don't know how many million did you vaccinate, but
we vaccinated 7.6 million doses.
Wow,
as of 6 a.m. today. And I'd like to publicly thank the President of the Philippine Medical Association, Dr. Benny Atienza. The idea of the National Vaccination Day came from him and his colleagues. We had a meeting in November 1. Naalala mo yun, holiday. Sabi ni Sec Galvez, I'm willing to meet with the PMA even if it's a holiday. So we met at 4 p.m. And one of the agreements was, let's hold a vaccination day. In fact, 2 weeks later ang plano namin. Pero we realized ang dami palang ipaplano sa vaccination day. So we ended up with the current schedule. And it was a resounding success. And it couldn't have been a success if it wasn't government alone. It was the PMA doctors, the faith-based organizations, and everything. So malaking bagay yun. And I also have to thank Omicron, by the way. Si Omicron variant, you are not welcome to the Philippines. But thank you, salamat. Tinakot mo ang aming mga kababayan at dinagsa yung aming mga bakunahan sa bayanihan bakunahan. At pag nakita mo susi yung picture sa aking social media, ay naku, hanggang alas 10 ng gabi, alas 11 ng gabi. Kaya yung mga report sa umaga, late. Hindi namin malaman kung ilan yung nabakunahan. So the other thing I'd like to state is that on November 29, the first day of Bayanihan Bakunahan, we logged a total of 2.7 million doses, which is the fourth largest vaccination in one day all over the world. We were only beaten by China, India, USA, and we are fourth. And then Brazil had a 2.2, I think, or 2.2 million in a day. But look at those countries that we are with, no? China and India are both over 1 billion. US is what, 400 million population. So technically tayo 100 million lang pero nakagawa tayo ng 2.7. Iba talaga yung Filipino spirit ng bayanihan. And we're repeating it. We're repeating it as our fight against Omicron. Uulitin pa natin na, this is the best time to do a vaccination drive. Di ba, Susie, in public health, you do not vaccinate when it is surging. You vaccinate during the ebb, when there is low. And we're having, for the past few days, less than 500 cases a day. Never experienced it. So the more we should continue. Many LGU said, Dr. Herbosa, tutuloy kami ha. We will continue to do bayanihan Thursday and Friday. So tumuloy pa sila. And also the other, for the next 15, 16, 17, sabi ko baka bayanihan, bakunahan week na lang, hindi na days. Kasi talagang ang daming pumupunta. And I do hope that happens because that is our best defense against COVID-19. So where are we now? 92 million doses given to Filipinos. 40 million fully vaccinated. 42, and that's already 45%. Basta almost 50% now of the targeted 70. And then 50 million have had at least one dose. So that was the beauty, no? I said 2.7 million were vaccinated on the day one. Well, the total is 7.6, but 85% were first doses. So that's interesting. So these are the hesitant people. And that's why I'm thanking Omicron. Kasi I don't think the bayan, I think they got scared. But I think the bayanihan, Filipino bandwagon mentality. Pag nakita nila may nakapila dyan, pipila sila dyan. Akala nila may nagbibigay ng ayuda. So madaming pumila.
Pero what was your first reaction when you heard about it?
Well, my feeling was I knew that the healthcare workers were pagod na. I knew si Jubert Benedicto, si Dr. Abalos, mga pagod na yan kasi 2 taon na nating binubuno ito and kita mo tumatanggo sila. Even the nurses are already leaving the Philippines, no? Because there were 8 million nurses in the US that resigned. Napagod na rin yung mga locals nila. So saan ba sila kukuha ng nurse sa Philippines? So natatakot ako. I also got scared because not at this time when people are careless, pinatanggal na nila yung face shield, di ba? They wanted more economy, opening the economy. And the scariest part when I was reading about Omicron was we were already going to relax in December 1. December 1 was our target day for Secretary Berna Romulo's opening up of the tourist destinations to people with visas that are 30 and 60-day passports, that are allowed to enter the Philippines. Dapat inallow natin yon in December 1. And because of Omicron, hinold din yon. So wala na namang kita yung ating mga tourist destination. Unless magbibiyahe si Dr. Abalos at si Dr. Jubert, which I doubt they will do because binabantayan nila yung kanilang mga ospital.
Nako.
Yeah, so I think this has really caught many of us by surprise. Partner, Raymond, ano bang naisip mo kaagad nung nasa Viber group namin kaagad yun na, uy, merong bagong Raymond, what were you thinking?
That's true. Also, very trivial, Dr. Susie, was because I tried to follow the serial sequence. So when I noticed that they picked a new name, I was trying to figure out why that was the name that they picked out. And lo and behold, that was part of the communications packet pala from WHO on how to explain why they skipped 2 letters and went to letter O. But more importantly, I was thinking more of what does this mean for us? I mean, kaalinsabay po kasi nung paglabas ng Omicron variant, are news saying na there are 50 mutations based on wastewater surveillance. Yung entire period wherein the Delta variant was at least in, I think, in South Africa, na in just a few weeks natapatan na yon ng Omicron variant just based on wastewater surveillance. So that was a little bit anxiety driving for a lot of us, but I still hold on to the fact that the vaccines still hold a high level of effectivity, and hopefully that's still also translatable to the new variants.
Thank you very much. Thank you very much to our panel for your willingness to start our webinar with a discussion. We usually don't do this, but it's great to just have that personal insight from all of you, and that's our segue to call our first speaker, who you know very well. He is a infectious disease and internal medicine specialist with the UP Medical Alumni Society in America. He's practicing in California right now. And you know him, Dr. Franco Felizarta, who's going to go now into the details of Omicron. Our title actually is Updates on Clinical Management. So we're going to hear about that from Jubert and from Jean, but we're going to start a little bit with a little bit more technical discussion from Dr. Franco. Franco, take it away. It's yours.
Thank you, Dr. Mercado. Magandang hapon po sa inyo lahat. Let me share my screen here. You're able to see it, right?
Yes, okay, Dr. Franco.
Okay, so yeah, I'm supposed to discuss the updates on COVID-19 clinical management, but of course we have this new variant of concern that was just designated by WHO. It says Omicron. Of course, if you're British, it's Omicron. So I prepared some slides for Omicron. So the first half of my presentation will be in Omicron, and then the second half will be on updates on COVID-19 clinical management. I have about 30 slides, but I'll skip about 10 in between. So hopefully we can finish this in less than 20 minutes. So these are my disclosures. Lots of pharma. I've worked with Gilead with the remdesivir clinical trials. I also work with GSK with the sotrovimab monoclonal antibody. And I'm a site for the NIH for Active2, and I'm a minor contributor for the research team. So let's start with the Omicron variant timeline. Is really more of the calendar. So it looks like Omicron was first detected in Botswana from a sample collected on November 9th. But most of the samples were from South Africa. So from November 12 to November 20, they noticed that there's an uptick of cases in Gauteng, Gauteng, Gauteng province of South Africa. Uptick of cases, some of them are reinfection, some of them are breakthrough cases. And they also noticed that more than 50% of the PCR tests that are positive has a S gene, spike gene dropout, we call it, or spike gene target failure. I'm going to talk about that later. So they sequenced all these 77 samples, and of course it came out to be a new variant. It's called B11529. So, and then they reported it, South Africa reported WHO on November 24th, and in 2 days, they designated it as a variant of concern. That's quite fast, 2 days. So from B11529 to Omicron. Now, why Omicron? So it's based on the Greek alphabet. Of course, we already have these 4 variants of concern. Alpha first detected in United Kingdom, Beta from South Africa, Gamma from Brazil, Delta from India, and of course the variants of interest, Lambda from Peru, Mu from Colombia, and the rest are previous variants of interest, including Theta. Theta is it was actually first detected in Central Visayas, Philippines. So we have data here. So the next one should be new, but they skip this because it's it's very similar to the word new, the English word new. And Psi, they skip Psi because it's very similar to a common name in China, which is Xi. For example, the president of China is Xi Jinping. So they skipped this and then went for Omicron. Okay. Now, before I discuss the mutation, let's just review the SARS-CoV-2 virus. As you can see here, this is the nucleocapsid here, which encapsulates the viral RNA. You have the matrix envelope protein, but the most important part here is the spike protein. And the most important part of the spike protein is this receptor binding domain, the RBD. Why? Because that is the one that attaches to the ACE2 receptor. There's actually a second receptor. It's called TMPRSS2. So this is actually important because of its association with the furin cleavage site between S1, S2 of the spike protein. This site makes it very unique among coronaviruses. Most of the mutations of the variants are in the RBD region. RBD is the receptor binding domain that attaches to the ACE2 receptor. So this is Delta versus Omicron variant spike protein. As you can see, Omicron has more mutations and most of them are in the RBD region. These are all 50 mutations of the Omicron. Okay, all 50, 20, half of them are unique, 26. Delta has 10. So in terms of divergence, Omicron is the most divergent of all the variants. 15 of the mutations are in the RBD site, three in the furin cleavage site. And if we compare it to the other variants, as you can see here, 417 to 501 are all RBD mutations. 681 is the furin cleavage site. So, for example, beta, in terms of neutralization, is the worst. Okay, beta is the worst. It has 2 mutations in the RBD and none in the furin cleavage site. How about delta? Delta is the most transmissible. It has 1 in the RBD, 1 in the furin cleavage sites. How about Omicron? Omicron has all of these mutations except 452. Okay. So what does it mean? So, we always have these 4 questions. Does it affect transmissibility, disease severity, risk of infection, or impacts on diagnostics? So let's start with impacts on diagnostics. The PCR continues to detect Omicron, so that's not a problem. It probably would not be a problem for antigen because there's not much mutation in the nucleocapsid site, so the antigen detects the nucleocapsid site. But you can take advantage of this S gene, spike gene target failure, or S gene dropout, which I already mentioned a while ago. This is similar to alpha, but remember, there's not much alpha now. So if you have a PCR test that has a S gene dropout, it's most likely Omicron. So of course, you still have to sequence it. So for example, I'll give you an example. Thermo Fisher TaqPath has it detects 3 areas of the gene: ORF1ab, nucleocapsid, and the spike. So if it's an Omicron, this 2 will be positive, but the spike will be negative. Why? Because of the 6970 deletion. If there's a deletion, there will be a dropout. So that's why alpha is the only other variant that has the 6970 deletion. So you can take advantage of it. So if the only thing is you have to use a PCR test that detects the 3, including the spike gene. And if the spike gene is negative, then you have a dropout. Most of the PCR tests does not do this. So for example, Sansure, I think in the Philippines, only detects 2, and it doesn't include the spike gene. So yes, it can still detect Omicron, but there's only a few, like Thermo Fisher, that can differentiate Omicron with other variants. So you can take advantage of that. Of course, you still have to sequence it. In terms of transmissibility, well, as you can see here, the beta was the most dominant in South Africa. It was outcompeted by Delta. And when you look at what's happening now, B11529 and Omicron is outcompeting even Delta. And it's actually, the dominance is much faster than Delta or Beta. So this is very concerning. Of course, this could be just because of the low numbers of, it could be just a founder effect due to, for example, a single super spreader event. But as you can see here, the surge in South Africa is real. It's starting. The deaths are stable, but remember, it lags behind by about 2 weeks. So the hospitalization will actually, we'll see if the hospitalization increases too. That could be a problem. Now, it doesn't help that the mobility of South Africa is now baseline. So this probably affected the surge too. If there's an increased mobility, of course, it can affect the, it can start a surge. So this could be a problem in countries where there's no ongoing Delta surge with low vaccination rates. It's now in 30 countries, okay, 30 countries, including, of course, United States, India, and Japan. Okay, it's also in Hong Kong. And of course, a lot of them are in Europe. So that is my presentation for the Omicron. I was, in interest of time, I was going to skip this. And now I'm going to change to the updates on clinical management. I'll be concentrating on the outpatient treatment options. Dr. Benedicto later will concentrate on the inpatient management. So this is the therapeutic management of non-hospitalized adults with COVID-19, according to the United States NIH treatment guidelines. And really, there's only 2 recommendations here. And so for patients not requiring hospitalization or supplemental oxygen, meaning the oxygen saturation is 94% and above, in the setting of emergency room, in-person, outpatient or telehealth visit, the recommendation is to give monoclonal antibodies in patients with mild to moderate COVID-19. Again, the oxygen saturation is 94% and higher, who are high risk of disease progression. Not for everybody, high risk of disease progression. There are 3 monoclonal antibodies that are available: bamlanivimab plus etesimimab, casirivimab plus indevimab, which is Regeneron, and sotrovimab. So 3. In the Philippines, I think you already have casirivimab plus indevimab, Regeneron. The second recommendation is they're against the use of dexamethasone or other systemic glucocorticoids, unless there's another indication. For example, if there's severe asthma, of course, you can use systemic steroids. These are the efficacy of the 3 monoclonal antibodies based on the phase 3 trials or published in New England Journal of Medicine. And for BAM plus etesimimab, the protection is 70%. It's quite good. So this is protection against severe disease, which includes hospitalization or death. So it's 2.1% for BAM, 7% for placebo. So this is highly significant. For the Regeneron, it's the same, 70%. And for sotrovimab, it's even higher, 85%. Now, remember, this is not a head-to-head trial, so I cannot say that this sotrovimab is superior to Regeneron or BAM. The only thing to remember here, though, is this is for Delta variants. Okay, so for example, BAM plus etesimab would not work against Gamma and Gamma and Beta variants. Okay, so there is some preliminary analysis that Regeneron could be affected by Omicron. And if it affects Regeneron, definitely will affect BAM. There's some preliminary analysis for sotrovimab that it will not be affected by Omicron. So these are the indications for treatment. These are the criteria for identifying high-risk individuals. This is according to the emergency use for United States. And this is for adults and pediatrics. So anyone 65 and above is considered high risk. A BMI of 25. Okay, so that's obesity. Pregnancy, chronic kidney disease, diabetes, immunosuppression, cardiovascular disease, and chronic lung diseases, and these are the rest. So this is not for everybody. It's just for patients who are high risk. How about oral medications? Do we have any drugs that are approved for COVID-19? So right now, there is no oral medication that is approved by the FDA in the United States, or there's also no oral medication that is recommended by the NIH. But there are three promising medications. One is fluvoxamine, which is an existing antidepressant, but it's not a popular antidepressant in the United States. You have the molnupiravir by Merck and Paxlovid by Pfizer. And in terms of efficacy, these are based on phase 3 trials. The reduction in severe disease at 28 days, this is only for high risk, 32% for fluvoxamine, 32%. So not very impressive, but this is significant difference. In terms of deaths, there's few deaths, but still impressive. 12 for placebo, 1 for fluvoxamine, 12 versus 1. It's given for 10 days, 100 milligrams twice a day. It should be given within 7 days of onset. It's actually quite cheap, just $4. However, NIH did not recommend neither for nor against the fluvoxamine, but this is based on data before this publication. Okay, molnupiravir is a polymerase inhibitor by Merck. And initially, this is quite disappointing. Initially, it was 50%, but when all the data came out, it decreased to 30%, almost the same as fluvoxamine, and barely significant. And for deaths, it's still impressive though, 9 versus 1. It's given for 5 days, 800 milligrams twice a day, but it comes in 200 milligrams tablets. So that's 4 tablets twice a day for 5 days. That's 40 tablets in 5 days. Should be given within 5 days of onset. Of course, it could be expensive. Although in the Philippines, I think it will be much cheaper. Then you have Paxlovid, which is very impressive. Okay, 89% protection against severe disease. For deaths is 7 versus 0. But remember, this is just from a press release, and the enrollment is only 70%. This can go down or this can go up. Okay. It's given within for 5 days with ritonavir, which is a booster, and it's given within 3 days of onset. If it's given within 5 days of onset, it's still effective at 85%. Now, in terms of mechanism of action, I mentioned that Paxlovid is a protease inhibitor, so it acts it blocks the translation of viral replication machinery, and molnupiravir is a RNA-dependent RNA polymerase inhibitor, so it blocks replication. However, it's at high concentrations, it's mutagenic against animals, so this probably will not be available for pregnant women or for children. Now, fluvoxamine is an antidepressant that has anti-inflammatory and antiplatelet effects. How about inhaled medications? There's no approved inhaled medication for COVID-19, and there's no recommended inhaled medication by NIH, but these are two promising inhaled medications. One is budesonide and one is ciclesonide. So in the phase 3 trial, there was a 32% protection for budesonide, almost equivalent to fluvoxamine and molnupiravir. In terms of deaths, 10 versus 6, low numbers. Ciclesonide is very impressive, 92%, but this is only for hospitalization, and this is a secondary endpoint. It was not their primary endpoint. And there were no deaths. There were no deaths in the study. Duration of treatment, 14 days for budesonide, 800 micrograms BID within 14 days of onset. And for ciclesonide, for 30 days, 320 micrograms BID. And remember, this is not recommended by NIH yet, just because these recommendations are based on data before these publications. So that should be it. These are the inpatient guidelines, but I'll let Dr. Benedicto discuss this. But just one comment, in terms of efficacy, it's quite low, 11 to 38%. So we really need better antiviral medications. Thank you.
Okay, thank you very much, Dr. Franco Felizarta. Excellent presentations. Always great to have you with us. And I think these clinical updates are so important. There are so many doctors who are listening to us right now. So I'd just like to thank you for that. And we'll have probably hear a little bit more from you during the panel discussion. Over to Raymond now.
Thank you, Dr. Franco and Dr. Susie. Very important key takeaways from Dr. Franco that we hope we could delve more into during the panel discussion. Our next presenter is a practicing pulmonologist, and he also serves as the head of the Critical Care Unit Management Action Team at the Philippine General Hospital. Please welcome again to the webinar, Dr. Jubert Benedicto. Dr. Jubert?
Yeah, thank you very much, Raymond, for that introduction, and Dr. Franco as well. Uh, so my main task in the next few minutes is to give you an update, short of a briefer only, as what is happening as far as the change in COVID-19 management, specifically in the Philippine landscape. And I'm glad Dr. Franco was able to give me a very good context. Napakaganda nung backdrop na susundan ko. So this is just my disclosure and disclaimer. I will share with you what my perspective as more as a COVID frontliner, both connected with Philippine General Hospital and Lung Center of the Philippines. So these are COVID referral centers. So I would like to start by saying, of course, that since we are looking at the evolution, this was the way we were viewing COVID-19 way back in 2020. So we do know that, as what you can see, we tend to be driven by the patient's symptomatology, by their presentation. Back then, we do acknowledge that there's that big chunk of being asymptomatic. Some of them will go to the symptomatic phase, the pneumonia, and then what we dread, the pneumonia with hypoxia. You can see as well that there was that main dictum to possibly start early, especially with the introduction of some medications. Di ba natandaan po natin the hydroxychloroquine, even though it was not really gaining some good traction initially, we tended to push for it, especially way back in 2020. And then subsequently, gusto po natin siyang ma-maintain. And then there was that lopinavir, ritonavir, that was a sort of nag-shift yung ating perspective. And basically, we were anchoring everything based on the patient's presentation, which is rightfully so. So even the PISMID, our local society for infectious diseases, came out with this sort of an algorithmic management. So para siyang flow in terms of how to manage patients. So basically, it is really anchored on the patient's severity of presentation, and their severity will subsequently dictate how will they be managed. So as you can see, even back 2020, there was that consideration for possibly IV remdesivir. Remember, earlier on, we started with remdesivir more as an investigational drug. Same goes with tocilizumab. And as you can see from this main algorithm, there was really, we should be securing the consent from the patient before they can be given the drug, even let's say if they are indicated and if there are no contraindications. So as you can see, it's still, we still went by in terms of how to monitor these patients. We were looking at the respiratory status, their hepatic status, and then of course their cardiac status as well. And then possibly trying to encourage the clinician to see if there are contraindications in terms of giving these drugs. If you're going to ask me way back in 2020, maganda ba yung evidence for us, to really push and in terms of giving these drugs? Way back then, medyo loose pa ho yung evidence, but there were signals there. Even if the studies, were not the typical RCTs, and in terms of levels of evidence, they were not that robust. It seems like at that particular point in time, if you're the frontliner and you're at the crossroads, mas magandang ibigay mo na lang siya, and then you hope na sana yung pasyente dun siya sa percentage na nag-respond. So even my society, the Philippine College of Chest Physicians, came out with this main algorithm, considering that we were seeing a big chunk of patients in respiratory failure. So you can see again, it's anchored on the severity, mild, moderate, severe, and then looking at certain prognostic indicator. As I mentioned, kasama na po sa kinukuha sa patients, CREA, so renal function, liver function, to see if you can give other medications. And then we looked at certain inflammatory markers. Respiratory-wise, in terms of support, you can see this main dictum that in terms of safety, we put premium safety po ng healthcare worker. So in order for us to be able to assist these patients with their breathing, we are calling on the anesthesia team. Sila po yung nagra-rapid sequence intubation. Of course, they are touted as the experts in terms of airway management. So mas mabilis sila ma-intubate yung patient, assuring safety for everyone concerned. Of course, having the proper PPE, etc. And then possibly giving the patients protective lung ventilation strategy, as you can see here. Way back then, as you can see, there was really that push even for the vitamins, di ba? May vitamin C plus zinc, and then not to use the nebulizers, use inhalers in order to lessen, of course, the spread of the infection, and then manage them accordingly if they have other presentation. And so let's shift gears a little bit. Latter part of 2020, this is the way we're seeing this COVID-afflicted individuals. Yes, we still look at them that maybe they are in the early infections phase, wherein viral replication is really the dominant process there. And therefore, mas maganda po ang pick up ng RT-PCR during that time. Once they are in the pulmonary phase, we do anticipate that the viral replication is already at a decreased phase compared to the, of course, earlier infection phase. But subsequently, we are seeing that once they are in the pulmonary phase, you see all imaging studies going abnormal. And then subsequently, we do know that if we could not stop the main process way back, they will go to this hyperinflammatory phase wherein we really see a lot of organ dysfunction. It's not just your pulmonary organ going awry. It's might be your kidneys, your liver, etc. And therefore, we realize the main contribution of what we term as the cytokine storm. And therefore, latter of 2020, we were seeing, as what Dr. Franco pointed out earlier, the possibility or the potential of under antiviral treatment. We were not having success with hydroxychloroquine. So we were looking at trying to shift our attention to other antiviral agents based on the concept that really is resting on science. So we do know that the virus behaves this way. And therefore, if your lopinavir is not acting optimally, we tended to try other antiviral agents which may be acting on the RNA replication phase. So doon na po talaga pumapasok yung remdesivir. Yes, there were some studies looking at baricitinib. This is a JAK2 inhibitor, trying to halt the process earlier on, but it seems not to get the proper traction it needs, unlike, let's say, remdesivir, and that will possibly give the rationale why is it incorporated in our guidelines. Subsequently, as I've mentioned, we did realize that a lot of our patients are dying from cytokine storm. Ayaw po namin mangyari yun, being in the ICU. We are seeing patients na kahit na mababa na, let's say, yung kanilang viral load, hindi na nga nag-RT-PCR positive, yet floridly, their imaging studies are shouting yung mga typical ground glass pattern or ground glass opacity. We are seeing organ dysfunction, various systems. It's not just confined to the lungs. And therefore, we do realize that maybe other agents may have, a rational role in terms of halting the cytokine storm. Dun po pumasok yung tocilizumab. So previously, yes, it was an agent that was introduced. Kaso ang alam naman po natin sa Philippines, mahal yan, di ba? There was a time, 2020, mahirap pang makakuha ng tocilizumab. And then subsequently, there were negative studies about it. It's not really improving survival as what we hope to, considering, of course, the cost. So nag-die down po yung use ng tocilizumab. And then when good studies were being produced, tapos lumalabas yung results, binalikan natin yung tocilizumab because we were seeing na, oh, teka lang, mukhang meron siyang protection against death. And so we tend to evolve in terms of our management just based on that cycle. Tinitignan po natin yung rationale niya in terms of scientific logic and then look at the studies, trying to see the proof of the studies behind it, if what they should do is actually working. And then subsequently going back to the patients, nangyayari ba talaga to sa patient? And therefore, as time went by, I would like this 2020 study came out late 2020, mga around November to December, specifically looking at how COVID is affecting our lungs. And so, we do know that once patient gets hospitalized, majority of the time because they are dyspneic, because they are hypoxic. And therefore, we did realize as well, if you're going to go by pathophysiology, it's not just the direct insult sa lungs which can account for that presentation. It is this edema, even the vascular involvement giving rise to microthrombi, etc. All of this contributes to the patient's symptomatology. And therefore, as you can see sa diagram below, dun po pumasok ngayon yung use of possible antiviral agents earlier on. We were looking at anti-inflammatory medications, especially if your patient will be needing oxygen already. Kasama po doon yung anticoagulation as well. And if it all else fails, we do know that hindi po makakatakas yung patient from being intubated. And therefore, even the PCCP now evolved in terms of its approach in terms of respiratory support for these COVID-afflicted individuals. So in contrast, hindi naman po siya dramatic na change. But in contrast to the first algorithm, subsequently, the algorithm that PCCP came out late 2020, nandun na po yung self-proning for awake cooperative patients. We do know that if we're going to intubate the patients earlier on, we might be doing more harm than good. And therefore, ito po yung gusto naming i-maximize. And as you can see, yes, andun na yung high flow nasal cannula. We do realize that there are certain tools available to see if our patient is responding to our non-invasive ventilation strategies. If not, then definitely the patient may be needing intubation. So yung earlier on na nauuna yung intubation, medyo naging latter part na siya in terms of our intervention. So in the Philippine General Hospital subsequently, April this year, we tried to integrate everything kasi nga na-observe namin during the surge, we could not rely just on infectious disease specialists and pulmonologists doing the management. So we were calling other colleagues from other disciplines. So let's say nephrologists, cardio, even non-IMs, nandun po yung mga surgeon, etc. And then encouraging everyone so that hindi po maging suboptimal yung standard of care. We follow this algorithm, so to speak. So as you can see, we still categorize the patient depending on the severity. And that will, in a way, dictate what will they be receiving. So we tried to do this during the surge because in response to that surge, we would like our standard of care or standard of management not to be sacrificed. No? So as you can see as well, incorporated during this particular algorithm, nandun na po yung role ng tocilizumab, the role of, let's say, remdesivir, and then subsequently other interventions like hemoperfusion. Let me now shift gears a little bit. Ito na po yung alam natin. And this is based on the Philippine Consensus Living Recommendations for COVID-19, which was updated just November 15, 2021. So around 2 weeks ago. I would like to share this with you. Of course, it's freely downloadable from the site. So in terms of remdesivir, quite consistently, it was still recommended for patients who have an O2 saturation. Its recommendation is against patients who have good oxygenation. So if they do not require oxygen supplementation, we don't give remdesivir. It is recommended to be given on top of dexamethasone for patients who may need O2 supplementation in order to maintain an O2 saturation of at least 94. And as you can see from this last statement, it is against the use of remdesivir in patients who are already on invasive ventilation. Dito po pumapasok yung ethics, no? Because remember, there was a time when remdesivir really was hard to find. So we were trying to, secure a resource and trying to allot it dun sa most possibly magre-respond. And so they've identified it, those who are O2 requiring, high flow, low flow. Pero kasi once na intubate yung patient, it seems like hindi po maganda yung outcome. And therefore, we were trying to conserve it to those patients. Having said that, I do know that especially during the search, we still were able to give it amongst patients who are intubated. Just bear in mind that they may not necessarily be working as good if the patient is not yet intubated. So how about tocilizumab? So as you can see, medyo gumanda po yung evidence behind tocilizumab. So the addition of tocilizumab on top to systemic steroids is recommended for patients showing rapid respiratory deterioration or requiring high flow doses of oxygen. That means high flow nasal cannula, either the patient being in non-invasive, yun po yung BiPAP or CPAP, or invasive mechanical ventilation, and with evidence of increased biomarkers of inflammation. So among those patients who will not require oxygen, tocilizumab should not be given. How about convalescent plasma? Earlier on kasi po maganda ang studies for convalescent plasma. Way back 2020, we were seeing good things for convalescent plasma. We were giving it, let's say, for patients who may not necessarily, we can catch, let's say, between 5 to 10 days of their illness based on their symptoms. Maganda po yung nakikita naming outcome. And so subsequently, it was resting on that good the logic behind it was rational, it was science-based, and so we were trying it out. But right now, there are studies, one of them emanating from Philippine General Hospital, to show us or to demonstrate that convalescent plasma did not have any advantage. And so if you're going to look at the COVID-19 living document, it is against the use of convalescent plasma. Other things for ivermectin, kasi po nag-hug siya ng headlines, di ba? Yung late 2020. Still, the living documentation, the COVID-19 living document, is against the use of ivermectin in all types of severity, from mild to moderate, severe to critical, even let's say among those patients who were given antibiotics. This is just a statement possibly supporting yung sinabi ni Dr. Franco kanina. The use of casirivimab and indevimab sa Philippines po, Ronapriv yung ginawa nilang brand name. So it's the same as Regeron, pero Ronapriv. And yes, it is available for emergency use authorization. And if I'm not mistaken, even the DOH conducted, I think it was a month ago, some seminars on how to use this, because this will be available in DOH retained hospitals. So as you can see, based on the evidence, as what was shown as well, maganda po ang performance niya in terms of mild patients, especially those who have high risk of developing or progressing to more severe forms. The risk factors that were included is an age of more than 50 years, obesity, cardiovascular disease, chronic lung disease, chronic kidney disease, or chronic liver disease, or other immunocompromised conditions. Which means, yung sinasabi po ng living documents, if you have access to this, maganda siya ibigay pag mild pa lang, especially if you can get the patients within 5 days of their symptoms. So ito po yung maganda sanang ibigay sa mga isolation facilities natin dahil mild lang, no? For hospitalized patients, the data is not that robust compared to, let's say, those who are not yet hospitalized, as what Dr. Franco mentioned. Napakaganda yung effect niya in terms of preventing hospitalization and possibly progress of that COVID-19 from mild. There are studies that was put forward as well and forwarded to the FDA in terms of post-exposure prophylaxis. Ibig sabihin, yung pong mga pasyente nating nasa household, let's say may 3 dong nag-COVID positive, yung isa hindi siya COVID positive, baka kailangan natin siyang proteksyonan. Your Ronapriv or your Casirivimab, Indevimab has good studies to show us even among healthcare workers na there might be a role in terms of post-exposure prophylaxis. Less po yung chances niya magkaroon ng COVID. Other thing, yung molnupiravir, as what was mentioned, as of now, there's insufficient evidence to recommend the use with COVID-19 infection. So this was as of November 8, 2021. That said, it's also available in a lot of hospitals right now sa Philippines. And I will say that for molnupiravir, the main studies in terms of its positive effects is yung sa mga milder forms, no, not for severe and critical. So other things, systemic corticosteroids, it's basically the same. Maganda po ang studies ng systemic corticosteroids. Main steroid type of steroid studied was dexamethasone among those who will require supplemental oxygenation. Consistently across the board, low flow, high flow, even let's say invasive mechanical ventilator, the patients who were given dexamethasone has an improvement in terms of lessening the patient's day on in ICU and mechanical ventilation. And they do not recommend the use of steroids among those who will not require oxygen supplementation. How about anticoagulation? Well, this is relatively an evolving field for COVID. There was a time wherein ang gusto po nating ibigay full dose anticoagulation, hindi lang siya prophylactic. But right now, the main studies are telling us that okay na po yung prophylactic dose of anticoagulation. So prophylactic over the therapeutic dose among those patients who are hospitalized from moderate, severe to critical. And then they recommend only the standard dose prophylactic anticoagulation among hospitalized patients with COVID-19 disease. So hindi po siya intermediate, hindi po siya therapeutic dose. For hemoperfusion, since it is readily available, especially among COVID referral centers, medyo magastos lang po talaga yung cartridge niya. As of now, there's insufficient evidence on the use of hemoperfusion as of this point in time. I know Lung Center of the Philippines has good experience in terms of hemoperfusion. We will be sharing the results of that study that was done locally. The signal is there in that if you see patients and you offer them earlier on, especially those patients who have increased CRP, other biomarkers of inflammation, i-offer mo to. It seems like it has a favorable outcome. So right now, I flashed earlier the one that we are doing in PGH. It seems like wala na po doon yung favipiravir. And then for the hemoperfusion, we tended now to be more selective kasi nga yung cost that is involved. So right now for Philippine General Hospital, we still resort to hemoperfusion among those who have contraindication possibly to receiving tocilizumab and other, let's say, agents. Possibly we can use this intervention more to really cushion the effect of your cytokine storm or your hyperinflammatory syndrome. So right now, this is the way we are viewing the shifting landscape of COVID management. I would say that concepts are still evolving. I might not be surprised, as what Dr. Franco pointed out, with the Omicron introduction, baka magbago ng konti yung management, but we are awaiting more data. As of now, I think we can really just rest on the evidence behind this intervention. I still think vaccines work in terms of preventing the severe disease, which is the form that we do not want. No? It seems like consistent pa rin po yung performance ng vaccines in terms of preventing that severe disease. But we just need to have an attitude that is willing to adapt. Hindi po pwede tayong maging close-minded kasi as what we anticipate, maybe what we know right now may change the following day or even next week or even in the next few days. And I do think even if we change our mind frame, if the systems do not change in order to make adjustment easier, it will be hard for the frontliner. So I'm talking about, let's say, hindi lang po sa hospital setting natin na systems, maskin sa community. I do feel that really the community can do a lot more in terms of trying to prevent these individuals landing in the hospitals and possibly not straining the healthcare utilization at this point in time. Mas maganda na po yung wala tayong masyado nakikita sa hospital. I do think that one hospital command or one hospital network right now yung term nila can do a lot in terms of trying to, let's say, shepherd these patients if they do need hospitalization to hospitals that can possibly accept them because they have a good complement of manpower and then of course the equipment that's needed, just to make sure that the services that we offer these afflicted individuals will not be sacrificed and will always be of good quality. Thank you for your attention.
Okay, thank you very much, Dr. Jubert Benedicto. My goodness, another excellent presentation. No? And Raymond and I were just texting each other na. You were showing the history of how treatment has changed. And I really like what you said na we have to be open-minded because the science is changing. And that's why this webinar is very important because we have to stay updated. Yung akala nating okay, a couple of months back, medyo nagbabago, no? And then we have the virus is also changing. I don't know, Raymond, did you want to say something before we go to the next speaker?
No, we just appreciated the fact that Dr. Jubert took the time to show the differences of the different flow charts and how it evolved from March 2020 to October 2020 and up to the present time. So not a lot would automatically notice those changes. They would rather refer to something that's much more easily consumable. But thank you to Dr. Jubert for that.
Oo nga, Raymond, kasi, sometimes the public feels na, ano ba kayo, pabago-bago kayo? Dati sabi nyo, okay, ngayon hindi na okay, no? But that is the nature of the beast, no? It is, we are all doing our best, I think, to bring the best information to you, our frontliners. And I think this has really been an excellent presentation just to show you that we do our best, but we don't always know what's coming next. So kailangan yung attitude natin iba, no? Na parang, mali pala yung ginawa natin, baguhin natin. No? That we're always trying to do better and always trying to serve our people with the best knowledge that we have. Okay, so that's our signal to go to our next speaker, who is medical director of the Chong Hua Hospital in Cebu City, huge hospital with more than 600 beds. And she's a specialist in obstetrics and gynecology. We'd like to welcome the medical director, Dr. Jean Abalos. Jean, welcome to the webinar, and please go ahead and share your presentation.
Thank you so much, Susie. I stand in awe of our two lecturers before me. And I would say that with the information that I got today, that will help me really with my role as medical director. When Estela invited me to talk this afternoon, she mentioned about sharing our data sa PIDSOG, to everyone, because we have shared this data basically to OB-GYN. So I would say that in the next 10 minutes, I'll wear a different hat. I'm an OB-GYN. So let me share with you the data that we have for the past close to 2 years. This may not really be 100% accurate, but it's a very good reflection of what we have because we are dependent on our members who are in the hospitals who have been giving us the data in the hospitals nationwide. So we have collected 2,674 confirmed pregnant patients. Unfortunately, as you will see here, most pregnant patients are young, so a lot of them, 89%, are asymptomatic and mild. We had 966 cases in 2020, which practically doubled in 2021, 1708. But I want you to take a look at the pie for severe to critical. It also doubled from 4% in 2020 to 8% in 2021. And if you want to look at absolute numbers, we had 87 severe and 58 critical in 2021. This mirrors what we see in the general population with an increased number of cases during the surge months. You see here April and August and September. But this one, I want you to look at. Mortality for 2021 is 5 times higher than 2020, so 85 against 17. And geographical distribution reflects the highly populated areas of the Philippines, like, for example, the National Capital Region, Central Visayas, Calabarzon area, Central Luzon, and Cagayan Valley. If you look at the pregnant patients, we did not have anyone in the first trimester. Most will be second and your third trimester. Take note that preterm births are increased among pregnant women with COVID-19, and their newborn are also more likely to be admitted in the neonatal unit. Cesarean section rate is higher compared to the general population for iatrogenic reasons. See, 59%. There is a bias to intervene. The threshold for cesarean is lower than usual because of 2 reasons. Number one, we want to minimize disease transmission with long labors and also for fetal indication for severe cases that we have. So the expert opinion today suggests that delivery should be expedited for patients in active labor. So live birth is still higher at 61%, but nevertheless, the 39% fetal death in utero is unacceptably high, which parallels the disease severity of the mother. No. So most babies are negative, while a lot have not undergone testing. So there is a possibility of vertical transmission, but it is in a minority. So in our series, only 4 were positive. This is a very powerful slide that I want you to look at carefully. While we know that pregnancy is a risk factor for progression, you see here that those who died are basically unvaccinated, 88%, or just first dose in 2%, and that's a good 90%. So this brings forward our plea for vaccination as an act of patriotism, and an act of love for our fellow men. I want to introduce you to PREVENT. What is PREVENT? It's a group of Johns Hopkins and the Ethics Division of the Kennedy, looking at guidance for preparedness, research, and response, like what we're having today in an epidemic. And they maintain that the absence of evidence, the mere theoretical or even documented risk of fetal harm, it's not sufficient to justify denying pregnant individuals access to a vaccine in an outbreak or an epidemic. Therefore, if you look at the principle of health equity during an epidemic, the default should be to offer vaccines to pregnant women alongside other affected populations. And I'm glad that this is also something that our government is rooting for, and also our specialty societies, as you will see in this slide. Therefore, I'd like to emphasize again, COVID-19 vaccination is recommended pregnant, trying to get pregnant, breastfeeding, or might get pregnant in the future. You will see from a lot of the studies that pregnancy increases a person's risk of severe illness from COVID-19. Therefore, in the general OB population, we need to modify our prenatal care. We alternate telehealth and face-to-face consultation. I'm sure that Raymond will be happy to hear about telehealth. And we try to consolidate our laboratories also with our consult schedule. So we limit the time that patients have to go and see us in our clinics. No. And of course, we advise them to be very vigilant, not to get infected, as we mentioned, because pregnancy is a risk factor. Now, let's take a look at pregnant patients. Multidisciplinary approach. I think Jubert also mentioned this for the general COVID patient, and this is more so emphasized in an obstetric patient. And of course, labor and delivery, hindi naman pwedeng sa ano lang tayo sa birthing center. We really need to be in a tertiary facility that will be capable of monitoring both the mother and the baby. What I want to emphasize here is oxygen supplementation, less than 95%. Magbigay na tayo because in pregnancy, we need to make sure that we ensure adequate oxygen delivery to the baby. And also because of the physiological demands of pregnancy. And lastly, our two speakers have mentioned the medications that are being used in pregnancy. So I'd like to say, as a general rule, do not withhold potentially effective treatment because of theoretical concerns related to safety in pregnancy. I think this mirrors the principle that we mentioned to you about the vaccines earlier. But of course, we emphasize shared decision-making, safety, as also against the severity of the maternal disease. It shows a few medications because these are the very popular ones today. So remdesivir, reassuring, well tolerated, therefore should not be withheld from pregnant patients if it is really indicated. No, I forgot to mention that the management of pregnant patients will be similar to non-pregnant patients. The only difference there, of course, will be the obstetric factors that we need to factor in. No? So corticosteroids, as obstetricians, we have been using your betamethasone, your dexamethasone, but only on a short course to decrease neonatal complications for patients with threatened preterm delivery. That's the famous research of Liggins and Howe. And we know from researches today the potential benefits, reduction in your maternal mortality with low risk of fetal adverse effects. Therefore, today, even in pregnant patients, we follow the recommendations as previously mentioned by our speakers. Use dexamethasone, mechanically ventilated, requiring supplemental oxygen, even if not mechanically ventilated. TOSI is very popular, insufficient data, but we know that they are actively transported across the placenta, which may affect the immune responses in utero of the exposed fetus. Therefore, today, the recommendation is against the use of tocilizumab during pregnancy, but of course, we have to be open. So there is still an area where collaborative decision may be done depending on the risk to the fetus and the present condition of the patient. This is the new kid in the block, your anti-SARS-CoV-2 monoclonal antibodies, recommended for the treatment of mild to moderate COVID-19 infection and post-exposure prophylaxis for people high risk for progression for severe COVID-19. I think this was illustrated very well early on. And I would say that if you look at the list, pregnancy is one of those at high risk for progression to severe COVID-19. Therefore, considerations in pregnancy, although we know that it is expected to cross the placenta, we have used other IgG products safely in pregnant people before, like for example, for your chicken pox. So today, authorized anti-SARS-CoV-2 monoclonal antibodies should not be withheld in the setting of pregnancy. And the last, and I'm very happy that this was also discussed by Jubert early on, antithrombotic therapy in patients with COVID-19. Again, as obstetricians, there are occasions that we already use this, like for our APAS patients, for example. The risk of thromboembolism is greater in pregnancy than in non-pregnant patients, but we don't have reported, this is not a reported complication even among women with severe disease. Therefore, the ACOG, American College of OB-Gyn, the SMFM, Society of Maternal Fetal Medicine, and our PIDSOG, VTE prophylaxis can reasonably be considered for hospitalized pregnant women, particularly for those who have severe disease and are critically ill. No? So that ends my presentation for the pregnant COVID-19 patient. And thank you so much for your attention.
Thank you very much. That's Dr. Jean Abalos of Chong Hua Hospital in Cebu. Excellent, another excellent presentation. I'm sure for the doctors who are out there, you want to go to the replay and see all these different slides and all these presentations, because the updates are really, really excellent. Thank you so much for that, Jean. Okay, so we are now eager to go into the panel discussion, because we've got Benny Atienza from the PMA and we've got Ted Herbosa with us. So we're going to move now into our panel discussion. I'd like to ask all of our panelists, our speakers, to open their videos. And while they're doing that, we have a public service announcement from TVUP.
Okay.
Wala pa, Raymond, kumanta muna tayo.
We're looking for tropang tigasan. No, I'm waiting for the prompt. Yeah, there we go.
Halaga ang lakad na ito. Tigasin ka ba?
Siyempre!
Mahal ba si Commander?
Mahal na mahal! Pare, mahal mo ba ako? Oo naman, ano?
Mahal mo ba ang tropa?
Oo ba?
Tara na! Magpapakuna na tayo!
Dahil mahal ko kayo, magpapapakuna ako.
Thank you so much, TVUP. The COVID Communications Public Service Announcement is one of the many outputs of the UP research entitled Communicating COVID-19 in Post-Quarantine Philippines. It's headed by the University of the Philippines Vice President for Public Affairs, Dr. Elena Pernia, and funded by the Department of Science and Technology and the Department of Health through its AHEAD HSPR project. We also would like to mention, baka po makaligtaan po natin na we understand that a lot of you are busy. So what we tried to do as part of our commitment to provide you with bits of information that's easily consumable is that we have selected presentations that we will feature in its entirety. Tinatawag po namin SCD shorts. So if you are, well, madalas po kayo nasa YouTube, meron po mga video shorts po na makikita, and hopefully you could watch them in the TVUP channel po sa YouTube if you go to youtube.com/TVUPPH. Okay, over to you, Dr. Susie.
Okay, thank you very much. So let's start our panel with Benny Atienza, who's the president of the Philippine Medical Association. And I guess the first question would be, how are we doing in terms of clinical management? How are we doing in terms of updating our hospitals, our practitioners in the field? And what else do we need to do? So obviously there's so many new things happening. Wala pa dun yung Omicron, ano? Pero yung sa current pa lang, ang daming mga pagbabago. So what's your assessment of this, Dr. Benny, and what do you think we should be doing? I'm gonna ask Ted the same question. Go ahead, please.
Actually, the one we are doing is that, especially in the children, the first ano po ng COVID, hindi kasama yung, especially in the Telehealth, hindi kasama yung standards of care ng children and the pregnant women. And that's one of our concern kasi dumadaming COVID sa bata and sa pregnant. And we have suggested sa PhilHealth that they should have assessment of our COVID management even sa adult every 6 months. Kasi like this na magkakaroon ng Omicron in case, and we do have to update our doctors every now and then, and especially to our FDA kasi yung the use of our tocilizumab is not yet accepted by PhilHealth and madaming gumagamit. We are still waiting for the drug to be included in the national pulmonary to be accepted by PhilHealth. It's one of our main reasons, and as of now, our promise that most of our claims for COVID-19 is not yet given to the doctors, and we have a lots of problem like now that different in the vaccine naman, we don't have the vaccine yet for our children below 11, and we do hope that siguro bigyan na ng FDA, Philippine FDA ng ang emergency use for the 5 to 11 years old like in the other country, the US and Europe areas, and we need to be vigilant and update our our countrymen, especially that we have now that the alert level 2, ang dami pong pupunta sa malls, ang daming how can we sustain and yung isip ng mga tao naglax ang ating health restrictions, and especially the mobility of our people around the world. And we do hope that yung once na merong news na nakaabot sa atin, we must trace. The important ngayon in this COVID is the tracing pa rin. Although we have a low case of COVID now, we don't want our people to be complacent.
Yeah, thank you very much, Dr. Atienza. Ted, I don't want to put you on the spot, but you're
No, definitely. I really want to answer.
You're on the board of PhilHealth, so
You don't have to announce that. well, the board is different from the executive, and I will comment on that also. But first, the question really of what I thought about all these presentations, our excellent speakers on the management of COVID-19 and updates. Remember, Susie, when we started this, what was our issue? Our issue, Susie, when we started Stop COVID Death, was there was confusion out there on what protocols worked and what didn't work. There was a lot of abracadabra medicine that was being practiced out there. And we implemented this program, which was a housing success. And I heard you're now nominated for Gawad Pangulo. Congratulations.
Congratulations to us.
No, but I think the viewership that we have here is a tribute to the fact that people are searching for answers. Now, the problem is we've come to approach this. I'm a disaster medicine expert, and I live in chaos. I mean, I thrive in chaos. The problem is a lot of my colleagues in medicine, clinical medicine, can't do that because they need to have the standards. They need to work with evidence and the policies. And that's the hard part. The level of ambition is wrong. The level of ambition we created for our clinician is the same level of ambition we wanted for our non-COVID era, which is, you have HTAC, you have evidence-based medicine, randomized clinical trials. When will you get that? You have a new variant that comes in. You have a new virus that's here. You won't get that. So I think people should learn how to work in the way we do in emergency medicine. We lower the level of ambition and we go out and try. No, will you be able to standardize? No, it is going to be a judgment call. And if you ask me, if I'm going to be treated by Jubert, I'll ask him, use your best judgment of what you're going to use to me based on my clinical status. And I think that's why you pay a doctor, his professional expertise. I don't want to be treated by a protocol. I don't want to be treated by a standard procedure. I want my doctor to think about my problem, my clinical problem, look at the research evidence that's out there and tell me, I think this is best for you. And I'm going to agree. As a patient, I will agree. Hubert, that's the right way to do it. Handle me with that type of therapy or a drug. So it seems that we can see it's like a pendulum. The knowledge is swinging back and forth, right? This drug works, then this drug doesn't work, this drug. But actually, over the past 2 years, I've been observing it. It's like a helical spiral. We're moving up, we're creating more knowledge, and we're able to have more confidence. And this is proven by the case mortality rates at PGH and at the rest of the country. So I think we need to put our level of ambition to a lower level because it's a new variant. and not expect that all these RCTs will come to us. Even our government regulators have suffered from the same problem. And I criticize, let's say, the HTAC for trying to implement strictly to wait for it. But you can't wait for that when you're handling a critically ill patient right in front of you with Omicron, right? For example. So I think I need to have my emergency medicine principles taught to a lot of clinicians who actually work out. So we talk about lowering your level of ambition, moving your resources to where it's available. So I saw the checklist of Jubert. That's the correct thing to do. Start thinking about my resources that I need if there is a COVID surge. What are the drugs that is available to me? Because we talk about all these new drugs, not all of them are even available in the Philippines. So sometimes people get confused. Patients get confused because they're coming to us, asking us doctors, well, give me this, get me that. And then they come to me in the NTF, doctor, saan makakakuha ng ganito, ng tocilizumab, ng remdesivir? When in fact, when I'm looking at how they're using it, it was against the principles that Jubert was presenting. They're giving it to even dying patients. So parang, I think a lot more important should be put on educating our clinicians based on our experts. I'm very happy that our experts here really share their experience and knowledge, and that's my statement on that. Now on the PhilHealth side, there's also a big problem in how we reimburse COVID-19, and there was a promise to actually pay everything, but it also created many things, because when you start to tweak health financing or health payment schemes, you start to change behavior. So not all, but some hospitals, I heard about it when I still wasn't in PhilHealth, upcasing their cases, fraud, talking to patients who had patients that died, and then you just agree we will put it as COVID, and you won't have to pay anything in the hospital. So these things I've heard, and that's the reason why PhilHealth behaves as it is and doesn't want to pay immediately. So I think there's a lot of work to be done on the reimbursement side. I think that's why we're confusing the lawyers at PhilHealth about all these clinical protocols, because we have so much scientific voodoo that they cannot explain. So I think we need to fix that. As doctors, we need to simplify how to treat a new variant, how to treat COVID, and give them the simplest, and then hope that is agreeable to almost all, a majority. I know for the clinicians, talagang may ko-kontra dyan. Gusto ko gumamit ng ivermectin, gusto ko gumamit ng tocilizumab, but at least we will have some level of consensus, and that way, parang yung tawag doon? Consensus building, maybe more of consensus building, so that we can spread all these great new protocols for treatment. Yun lang, Susie. Thank you very much. Sorry na grant.
Yeah, thank you, Ted. I think the three of them, Jubert, Jean, and Franco, all alluded to what I would call the art of medicine, right?
Yes,
yes.
exactly.
You have protocols, you
Judgment.
have some standards, but you always, and Jean talked about, discussing with the patient and making sure that even if you're using something na sinasabing wag gamitin, pwede mo rin gamitin kung tingin mo.
Of course.
So I think the problem really is that our patients go to the doctor and say, si kapitbahay gumamit ng remdesivir, bigyan mo rin ako yan. Di ba? Parang
correct.
So,
Ganun na nangyari.
Yeah. So, Jean, you want to speak to that, Jean?
First of all, I want to thank Ted, because I know now that for pregnant patients, it's already free PhilHealth, because of PhilHealth as far as the testing is concerned. Because we're very, very particular about our pregnant patients coming in tested. Naman ang condition when you're in the delivery room, no? So the high rate of aerosolization, etc. So very important for us. And then, yes, Susie, I agree with you. Not everything can be put in a box. Always, the family, the patient should be part of our decision making. Like if you have a very critical patient who you believe will really respond to your steroids, then why not? Even if there is a baby inside. And I believe that I also took a look at the ethics part. That's why I presented the group of Johns Hopkins, because they look at the principle of equity. I think you and I will agree that as far as research is concerned, nakakalimutan ng pregnant, or maybe hindi nakakalimutan, it's more of we are afraid of the pregnant patients. But now they're saying we should include them, especially if scientifically we have data that these medications may have evidence of safety, like in animal studies or from previous indications. No, so we are not robots. We need to assess as we go along. That's why I also like the last slide by Jubert. We need to adapt. We need to listen always, because how can we adapt if we do not know what's happening, especially with a novel virus like this is, no? Yeah. So that's it,
Thank you
Susie.
Thank you. Jubert,
Yes.
marami bang pasyenteng at saka mga family na dumidikta? Kailangan ganito, Doc, ganitong bibigay nyo.
One of the things that we had to learn, pero I'm sure not all doctors are doing, is really taking time to talk to the patient and their relatives. Remember, this is a pandemic, especially during the surge. Ang hirap po kumausap sa mga relatives via Viber lang, telehealth, kasi wala talagang personal connection, ano, unlike before na nandun lahat. Tapos dun, tandaan nyo, surge yan. So halos tumitingin ka, let's say, ng 20, 30 patients sa ICU. Tapos after mo matignan, gusto mo mag-family conference ideally kada isa. No, para masabi mo, so you can share with them what do you think the status of the patient is and what you think you need to do at this point, and set then their expectations. So I think that was the main challenge right now. Tama ma'am kayo, Susie. Sa PGH lang po, there was a time na, let's say, kumonti na lang yung tocilizumab, let's say, sa pharmacy. So winawire na kami ng pharmacy. Doc, wala na pong tocilizumab sa Pilipinas. 10 vial na lang po yun nandito sa amin. So consciously, we were really trying to, yun na nga, masama man pakinggan, we were trying to allot the resource dun sa talagang makikinabang. So makakadinig po kami ng ganon. Doc, ang alam po namin, kayo daw nagdidikta kung sino daw po kuha ng tocilizumab. So pwede po ba yung para po sa akin, just in case ma-hospital ako, wala naman po ako, hindi ako na-hospital, bigay nyo na lang sa asawa ko na nasa ICU ngayon. So may ganun pang hirit. So I will say that as doctors, parang uncharted territories yon. We were doing some things na, you know the science behind it, pero tama si Dr. Ted in saying na hindi, dapat yung art nandyan pa rin, dapat ma-discuss mo sa patient. Here you are trying to tell the patient, alam niyo po yung tocilizumab hindi po mag-work sa asawa niyo at this point in time. Tapos sasabihin niya, ano na lang po, Doc, mag-work? Wala na po, nabigay na po natin lahat, let's say. So I in some instances, I just allow, let's say, the patients yung relatives ng patient in full PPE naman sila. Tapos I'm there at the bedside just to hold their relatives' hand. Tapos yun po siguro yung parang mag-a-accept na sila at that particular point in time. No, they will accept na wala ka nang maibigay, or as what Dr. Ted mentioned, hindi naman na talaga available dito sa Pilipinas So kahit nababasa mo sa internet, parang hindi practical na ibigay pa natin at this point in time. So humbling po yung experience na yon. So I will say na dati siguro sanay tayo, especially even during the COVID nung wala pang surge, no? Alam natin yung gagawin, protocolize yung approach, but then again, you will be humbled by the experiences na hindi mo alam lahat. Tapos sometimes the patient will be the one, the relatives of the patient will be the one to dictate to you in a way, ano po yung sa tingin niyang maganda. But you really just have to, take a deep breath and then balance out everything. Kasi at the end of the day, as what the other panelists have mentioned, ano yan you are trying to personalize your approach. It's based on science, but it should be tempered to a huge extent, of course, by the art behind it.
Thank you, Jubert. Franco, if you compare how doctors pick up on updates in clinical management in the US compared to the Philippines, what would your observations be?
Well, we're fortunate we have the CDC, so they're very aggressive in educating the at least the healthcare workers. So and we're fortunate that we have more choices. For example, let's say tocilizumab. We actually don't have tocilizumab right now in the United States, so we're not using tocilizumab. But fortunately, we have baricitinib. So we have another medication that we could use. So, it's very hard to compare United States and the Philippines just because we have more resources and more choices. But if you think about it, as a whole, as a worldwide, we're fortunate that we have 3 cheap products that work, right? Vaccines, masks, and dexamethasone. I mean, steroids. Those are all cheap. So we're very fortunate that we have this armamentarium against COVID. Otherwise, it would have been a disaster.
Yeah, I mean, you mentioned the CDC, and I think we have a question from the audience, but I just wanted to comment a little on that. No, parang end of the day in the United States, the CDC is like Supreme Court, right? Says, this is the way the treatment should be and should not be, which I think, unfortunately, we don't have in the Philippines. Raymond, am I saying that out of turn, or Ted? Is that correct?
That's correct.
Parang,
Well, hopefully we could have one soon, but not yet now.
parang when it came to the standards of care, the protocols and the treatment, we've left it mainly to what? To the professional societies. What is it, Ted? I mean,
That's correct. That's correct.
Other
Susie. What we
medical
did was
societies.
we had silos. And if it's a trauma case, they ask trauma surgeons to make the protocols. For a cardiology case, they ask the cardiologist. But we never had national guidelines, just like, for example, NICE in UK for the NHS, or CDC in the US. And we tried to implement that now, but we cannot come to par because it's infantile, it's neonatal, our birth of the HTAC and all this stuff. And it was created at a wrong time when we had a pandemic. So I think we should have stuck with our protocols, created our system based on what we had, which is societies actually creating and giving their collective consensus dialogues, and then letting the government and the regulators listen to that. Ang hirap nun kasi they're conflicting ang nangyari, they're conflicting. We are birthing a new system, the universal healthcare law, with the HTAC policies and the new FDA laws and everything. So medyo it came at a bad time. It hit us at a bad time. And of course, we didn't invest. I think the real bottom line and the bottom dweller here is that we never invested in healthcare for the many decades, and we've suffered because of that in this COVID pandemic. Yun lang, Susie.
yeah, thank you very much. Okay, I think we have a question from the audience. Raymond, you want to take it?
Yes, we have one who has joined us actually in the panel. I think Mr. Camilo Nogoy has a question, and it's one of the more upvoted questions. Go ahead.
Hi, good afternoon to everyone. My question is about virology. I'm a non-medical person, but I've read in some books that viruses usually mutate to be weaker, so it won't kill the hosts. So what are the chances that this Omicron variant goes in that direction, that its mutation is towards becoming weaker and turning this COVID pandemic into an endemic one?
Oh, I can answer that.
Yeah.
Oh, Franco.
Go ahead, Dr. Franco, as the IDA specialist.
So this is the problem. The overall infection mortality rate of COVID is actually not very high. It's not like Ebola or smallpox. The overall infection mortality rate it depends on the median age of the country. It's from 0.5 to 1.5%. So overall about 1%. So that's actually compared to other pandemics is lower. So you cannot use that what you call this concept with COVID. COVID can still go up. It can still go up in mortality, and it won't affect the transmission. So that's the problem. It's COVID started low, and actually sometimes that's the problem when you have a significant but low mortality. A lot of people will gamble with that risk. Let's say if it was Ebola, 10-20%. All of them probably listen right away. But with a 1%, and there's a big difference too with age. So for example, if it's a 90-year-old, the chance of dying is 10% versus like a 20-year-old, which is 0.01%. That's a 1,000 fold difference. So people with a lower mortality will gamble on this, and their behavior will change. So it actually increases the risk of transmission. So yun ang naging problema with
And may I add to this? May I add to the comment? Because from a public health perspective, even if the virus has a lower mortality, if it is highly transmissible, you'll have more problems. Look at measles. Measles has a reproductive number of about 16. And we have deaths of measles. And during my time when I was an ER doctor, we had seasons, like during the cold season, children were dying of post-measles pneumonia. But it doesn't kill that high. But if you have so many that are infected, then the explanation of Franco actually works out, because ang daming namamatay na bata. Ganun din yung sa influenza. When there's now influenza season, all these elderly start to die. So it's not true that you want this virus to be more transmissible and less fatal, because in the end, they both will kill huge numbers as well, and stress hospitals. So a highly transmissible bug will overload the health system, and the Philippines doesn't have a great health system. We've got a lot of infrastructure gap and human resource gap. So a highly transmissible virus that enters here will decimate the system. Look at what happened in India. So that's why when people say the Philippines is too strict with its quarantine laws and its public health measures, we were protecting the health system, because if it collapses, more people that shouldn't die will actually die. So hindi rin ganun yun. Sino yung nagtanong? Hindi rin ganun kasimple yun. You just want the virus to mutate to a more transmissible and less mortality. Kasi you might end up with more problems, as what Franco said. Thank you.
Well, from the epidemiologic triad, which is the agent, host, and environment, right? So even if your agent weakens, if your hosts are in this case, right? We've seen that comorbidities, hypertension, diabetes, whatever it is, right? Can create severe disease. No, so that's only one factor. So the virus is only one factor. The other factor is the environment, because in the Philippines, 1 out of 6 people lives in a slum with a multi-generational household, no, na magkakasama matatanda, bata, etc. So we have to really look at the triad, the agent, the host, and the environment, in order to understand how you're going to control it. And that is correct, right? We have put in very strict measures, precisely because we have environments that are conducive to infection, not only COVID, but tuberculosis, dengue, etc. Plus, we have a huge high-risk population. 1 out of 4 Filipinos is hypertensive. So, so I think the virus is just one part of the equation, but I think it's a great question, because we all want it to be like a common cold, right? We want it to be weak. Raymond, did you have another?
Can I add one? Can I add?
Go ahead,
to that?
Dr. Franco. Go ahead.
Yeah, Franco.
So this is not just theoretical. So remember, from the ancestral virus, you have alpha, and alpha is 50% more transmissible. But there's some data that's actually more severe. And then from alpha to delta, it's 50% more transmissible. There's actually data that it's actually more severe. So it's more transmissible and more severe. So every time it mutates, it's actually worse. So this is not even theoretical. It's still it can go to both directions.
So, Franco, are we saying that we don't know? This is the problem, no? We don't know what this is going to look like in terms of severity. Right now, we don't know. We don't know that.
No, the problem is that we have anecdotes where there's anecdotes that the symptoms are milder, but there's anecdotes too that younger patients less than 4 years old are actually more affected. So I think we probably need another week or two, and we'll see the hospitalization rates. So the cases will go up, and we'll see if the hospitalization rates go up too. And of course, the deaths, the problem is will take about 2 weeks. So we'll see from the hospitalization rate. So if it goes up too, that could be a problem.
Yeah, and you've talked about this before, no? The decoupling of the number of cases versus the number of deaths, of severe cases. Okay, unfortunately, we are out of time, and we are going to ask you now we're going to ask you to compose your last few words to our audience. It's been a great webinar. I think everyone learned a lot. And Raymond's going to launch our evaluation form, which I hope will work this time. So pasensya na po kayo sa audience. Last time nakita ko sa chat na kayo naglalagay ng evaluation nyo. So go ahead please, Raymond.
Thank you so much. So as we give a few minutes to our panelists to gather their thoughts for their final messages, in front of your screens are the questions that form part of our evaluation poll. As mentioned, wala po kaming inilalabas na iba pa pong evaluation poll. Ito na po yun. So hopefully those who are more than 800 attendees in our webinar are able to participate in this evaluation poll po, no? The 5 questions that we have are as follows. The panelists demonstrated thorough knowledge of the topic. And as mentioned in previous webinars, it's a 4-point Likert scale. Strongly agree, disagree, and strongly disagree. Second question, panelists were well prepared and organized. Third question, panelists spoke clearly and audibly. Number 4, panelists use appropriate language with technical medical jargons adequately explained. And number 5, the panelists contributed to new perspectives and knowledge on managing various key COVID-19 health issues. We will not be closing this evaluation poll, and I'm very hopeful that it won't be closing prematurely anytime soon now. But before we ask our panelists, we'd just like to show to everyone who is asking, whether in Facebook Messenger or sa email po, that only those who have attended at least 50% of the webinar duration, they will be the ones who will be receiving po ang ating certificates of attendance. Ito po ang example ng ating certificate of attendance. We made it a little bit more the holiday spirit. With the holiday spirit already para to match the theme, and hopefully that's something that will be able to cheer everyone up. But yun po, those who are asking, we have already distributed all 80 certificates for all 80 webinars. After this one, we will be looking at our databases also. So if you feel that you should have received or have any problems, please continue to follow up and let us know. We receive a lot of emails with regards to names, etc. So we thank you for your patience, and hopefully that's something that we could rectify. Maraming salamat po, and we go to Dr. Susie for the final messages from our panelists.
So Ted has to leave, so he takes the first crack at the closing remark. Go ahead, Ted.
Thank you, Susie, for giving me a crack at the first step. Let me just mute the other one. Okay, so I think I'd like to thank you for doing this particular topic on Omicron. Like the beginning, when we started this way back last year, there was a lot of uncertainty, and today with the threat of Omicron, it's still a lot of uncertainties again, whether the vaccines will work, whether it be more transmissible. And we've got to learn to live better and work better in levels of uncertainty. So I'm really espousing for our a change in paradigm of a lot of our clinicians and our healthcare professionals, because we need to change our level of ambition. We need to look at the resources that we need to handle. we need to learn how to triage. And really, I think that was a lot of difficulty of our critical care people, because they're used to throwing the book at our critically ill patients. And then they were put to conditions wherein they would choose which one gets the ventilator, which patient gets the last vial of tocilizumab, and that's unnerving for them. We do that every day in the ER because we have to choose who gets to be admitted in the ICU, and we choose which ones are survivable. So we have to look at changing the level of ambition, looking at survivability as well. And we need to invest in the system. I think we all need to work together. I think the 4 C's of disaster medicine continue to apply: communications, cooperation, collaboration, and coordination. So until all of us in the different specialties really coordinate and work together, we should be able to beat this. And we're succeeding, actually. The Philippines is succeeding. We've been getting very low rates of new cases, and I really appreciate the work everyone has put in. And I congratulate the PGH people, Chong Hua, all those people, even our colleagues, our kababayans who give us information from abroad, firsthand, new information about how they're doing stuff, because we learn from them as well. So thank you, Franco, for sharing a lot of information that's mostly new and not yet known to everyone. So thank you also to Susie and also Raymond and the team for doing this. I think your success is really the fact that you have a following already, and that you continue to provide good knowledge and a good platform for communication against COVID-19. Thank you, and good afternoon, everyone.
Thank you very much, Dr. Ted Herbosa, Special Advisor to the National Task Force. All right, let's go to Dr. Benny Atienza, who is the President of the Philippine Medical Association. Benny, over to you.
Yes, again, thank you for this privilege, and it's a great time for us, the Philippine Medical Association, again, to be part of this webinar. At malimit kami maging guest dito. Excuse me. Again, as WMA said, we must protect ourselves as doctors before we treat others. Kasi during the first, second, and third surge of COVID-19, marami po tayo na walang kababayan. And we must, again, go to the first line of our defense. We must use our mask, PPEs again. And during the surge in our Catanduanes and Batanes, we gave po PPE kasi yun ang unang protection ng mga doctors in Batanes and Catanduanes. And as like said, we must do our part, everyone. This is a community effort. This is a PPP, private-public partnership must prevail, like our bayanihan sa bakunahan. And we saw that pag kumilos po ang lahat, even the community, kikilos lahat. And we always remind our audience, our community, not to be complacent this time in nandiyan po ang ng COVID, ng pa natin, ng Omicron, and we don't know kung makakaabot yan here in Manila or other parts of the country. Samantalahin po natin ang geographical area ng Pilipinas. We are islands po, and dapat maano po natin ang mobility. This is one important, kaya po nag-surge ang mga COVID natin. Hindi po tayo nagsasabi ng ating travel history, kung saan tayo nanggaling, and the symptoms. This one way we can protect each other po, maging tapat po tayo sa bawat isa sa atin, even lahat po. And during this time, nandyan ang threat of the Omicron, and we don't have any vaccine yet allowed for the 11 to 11 below years old. And we know that the more bata po ang naapektuhan ng ating bagong variant. Let's be vigilant and protect our children, even our vulnerable member of our community, the immunocompromised, our senior citizens, and all of our members in the family po. Thank you po.
Thank you very much. It's Dr. Benny Atienza, President of the Philippine Medical Association. Let's go to Dr. Jean Abalos, Medical Director of Chong Hua Hospital in Cebu City. Jean, go ahead.
Yeah, thank you, Susie. I think we know a little more this year compared to last year, but what's happening today is telling us that there are a lot of things that we still do not know. So, and as medical doctors, we really need to be on top of the problem for us to better serve our patients. No, as medical director, I would say that I'm lucky that I have good infectious disease specialists and pulmonary physicians. However, one of the things that I'd like to say now is how can we really manage a lot of severe critical patients if we are already overloaded? So number one, I'd like to again say that we need to ramp up our vaccination program. UPMAS Cebu, we are looking into vaccine hesitancy, and we go to huge companies to be able to convert their employees, those who do not like to be vaccinated. And somehow I think we're quite successful, and I'm thankful to TED for their vaccination program. Number two, I think we still need to educate not only our patients, but also our clinicians out there. Ang hirap-hirap pagka you have more than 100 waiting patients and some of them are severe to critical. As mentioned, sometimes there is only so much that we can do. So we need to do this together, all sectors together. Thank you, Susie. Yeah.
Okay, thank you very much, Dr. Jean Abalos of Chong Hua Medical Center. Okay, let's go to Jubert Benedicto, head of the critical care unit of the Philippine General Hospital. Jubert,
Yes,
over to you.
yes, thank you. So, ang masasabi ko lang siguro is amidst all this fear, there's that always influx of medical knowledge. But I think we need to have some order for us to get the proper things from this influx of knowledge. So I think we need a systems approach more in order to really combat this COVID. And hopefully we should not have parochial perspectives already, and let's all be open to dialogues. That's all. Thank you.
Thank you very much, Jubert Benedicto, CCU of Philippine General Hospital. Okay, and Dr. Franco Felizarta, who's almost like our in-house US-based infectious specialist. Franco, over to you.
Yes, now, with the advent of Omicron, remember, we still have good strategies that we can use against it. To prevent transmission, we still have masks. It will, it still works. We actually have a randomized trial showing it works. The latest meta-analysis shows that it might be even better than social distancing. The only thing is it has to be well fitted, or you can do double mask. It will prevent transmission. Number two is, even if the variants decreases the efficacy of vaccines against infections, the vaccine still has great protection against severe disease, hospitalizations, and deaths. And third, with regards to waning, yes, there's some data that there's waning for protections against severe disease in the elderly, 65 and above. So it's very important for the elderly to get their boosters. So masking, vaccination, and for the elderly, if it's available, get the boosters. I think those three strategies will work against Omicron. Thank you.
Thank you very much. It's Dr. Franco Felizarta, infectious disease specialist. Okay, before we go to our closing remarks, Raymond, did you want to summarize the outcome of the evaluation?
Thank you, Dr. Susie. So, okay, there we go. Can we share that? Okay. So, we have 638 respondents, which is relatively high for compared to our last month and a half webinars. And most of them, 95%, 94%, also on average 95% indicated that they strongly agreed with all of the questions as stated here. Very, very consistent with our previous webinars. As mentioned, we always aim to provide quality content and strive to and endeavor to make sure that all of the information that we provide you is credible. And that's the reason that we try to get all of the experts to form part of our speakers for each webinar. So maraming salamat po sa inyong mga suporta. Hindi lang po sa mga nandito sa Zoom, pero pati na rin po sa mga nanonood sa TVUP channel sa YouTube and sa Facebook po, where we are live streamed sa TVUP, sa University of Philippines, and Stop COVID Deaths. Over to you, Dr. Susie.
Going to our closing remarks, and we'd like to call on the Deputy Director for Operations for the Philippine General Hospital, Dr. Stella Marie Legaspi Jose, who's going to give our summary. Stella, over to you. Oh, nawala yata si Stella.
Ayan.
Okay.
Thank you for this opportunity to do the closing remarks. It has been a very enlightening lecture webinar, and I really appreciate Dr. Franco. You know, every time he speaks, talagang I want to be here to be present. And it's what he said about the Omicron is because he came from the US, so and he's quoting CDC. They think that it might be more transmissible, but as he said, we have to wait for more data. And he said monoclonal antibodies for mild to moderate illness for non-hospitalized patients. So the indication for this is when the patient is high risk, and as an OB, pregnancy is considered a high risk condition. So the elderly, the immunocompromised, and those with malignancies are considered high risk. And he mentioned about oral meds and the efficacy. So here in the Philippines, we were all very excited about molnupiravir, but in his lecture, he said 30% lang yung efficacy, fluvoxamine 32%. So Paxlovid ang 89%. So we'll wait for that. Dr. Franco. Dr. Benedicto, Jubert presented the management of COVID from the start. No? He was already part of the COVID crisis management team. He presented the 2020 up to the present, the management. He mentioned remdesivir and dexamethasone still being used here, although in the States, in his presentation, Dr. Felizarta said that they are not so much anymore with remdesivir, also tocilizumab. But here in the Philippines, we still use tocilizumab and systemic steroids, especially in patients who are deteriorating rapidly with rapid respiratory deterioration. Jubert said no to convalescent plasma, no to ivermectin. He mentioned that in non-hospitalized mild patients, we can give casirivimab, imdevimab, and these are given to mild and with at least one risk factor. Molnupiravir, he said, has insufficient evidence as of now, and dexamethasone in patients who require oxygen supplementation. He also mentioned about the prophylactic use of anticoagulants. And here in PGH, we still do hemoperfusion, although there is insufficient evidence on its use. Okay? But parang last-ditch effort na namin yan dito, yung hemoperfusion. So our renal unit is really very busy. With Dr. Jean Abalos, who is my co-OB, also a member of the PIDSOG, she emphasized that vaccination is really important in pregnant women. And when she cited the data that we have in our society, the mortality for fully vaccinated pregnant women is 0. With one vaccine received, one dose of the vaccine, the mortality is 2. The unvaccinated, the mortality is 75. 75 pregnant women died. Okay, so I think that's a very shocking piece of information, and I think all pregnant women should be vaccinated. Really. So ang sinasabi ng society namin beyond 14 weeks, but it says that if there's a caveat, if the patient is a high risk pregnant woman, for example, she's a healthcare worker, high-risk job, healthcare worker, she should be vaccinated because the benefit outweighs the risk. Okay? Na-mention din ni Jean yung principles of health equity, and then yun nga, pregnancy increases the pregnant person's risk of severe COVID. She mentioned about the multidisciplinary approach and being admitted to a tertiary facility. Again, she said that remdesivir should not be withheld in a pregnant patient, especially if it's indicated. And dexamethasone, its use, it decreases maternal mortality and decreases the risk of adverse fetal events. Again, tocilizumab is if the benefit outweighs the risk. And VTE, should be considered in all our pregnant women. I think for today we had a very good set of speakers, and thank you to all of you to your time, Dr. Benny Atienza, who's always very willing to help us in our TVUP. Hindi pa niya ako tinanggihan kahit minsan. Thank you, sir. All to you, Susie.
Okay, thank you very much. It's Dr. Stella Legaspi Jose, who's the Deputy Director of the Philippine General Hospital. And thank you to all our panelists. It's been a great webinar. Great having all of you here. Next week, we have a very interesting topic. We are going to talk about, Raymond, tulungan mo na ako dito. Parang ang topic natin, will we ever control COVID-19?
Yan ang hirap ng topic. That's why we got an expert to lead the discussion for next week. So we are very privileged to have her. Hindi niyo po siya kilala, joke lang. Pero she will be joined by 3 reactors, from the younger generation. 1, a medical anthropologist. 2, a representative, hopefully from the Department of Health. And number 3, someone who's working in the public health front lines and used to be affiliated with the MSF or Medicine Sans Frontieres. And it will be really an interesting topic just because when we were trying to schedule this, the new Omicron variant was still not yet around, and we wanted to be able to cover several different aspects from a public health perspective, and this was one of the more challenging topics, and we wanted it to be our last webinar for the year, which brings me to the point na next week na po ang ating huling webinar for the year 2021. We will be going on a brief hiatus and we will be coming back in mid-January. Hopefully, hindi po kayo magulat na wala po kaming webinar towards the end of December and the first part of January. We hope to be able to bring you with the latest and up-to-date information through our webinar. Wag po kayong magsasawang tumangkilik, and something that we hope everyone will be able to encourage their families, relatives, and co-workers to join our credible online community.
Ano kasi nasabing speaker, Raymond?
Ang speaker po natin ay walang iba kundi ang aking partner, si Dr. Susie Pineda Mercado. She will be tackling different aspects of the public health field. So ano po ba yung pandemic, epidemic, endemic? Ano po ba ang kailangan nating malaman patungkol sa Omicron variant? Hopefully, there will be more information in a week's time. Additional information in a week's time. The different terminologies we keep on hearing. Herd immunity, is it still within our reach? Is it really a realistic goal for us? So all of these topics will be covered hopefully next week by our excellent panelists for next week. Dr. Suti, did you want to add anything?
Baka sa kaka-announce mo, Raymond, wala nang dumating next week. I'll do my best, guys. So, it's a difficult topic. Will we be able to control COVID-19? It's a very difficult topic, but I will rise to the challenge and I'll do my best. So I'll see you next Friday.
Thank you, Dr. Susie. Before we conclude our program, let's first acknowledge the following. These are the men and women who are working very, very hard behind the scenes to make this learning series possible. Without each and every one of you, hindi po talaga tayo magkakaroon ng credible online community for this Stop COVID webinar series. So maraming salamat po sa lahat. And finally, all Stop COVID Deaths webinars are archived for viewing. You can watch it at the playback at the YouTube channel ng TVUP. It includes all webinars from webinar 1 nung nagsimula po tayo nung April all the way to webinar 80, which was last week. Right after this webinar, we will also be archiving this webinar so that you'll be able to watch it. I'm sure there are those who are really hankering to be able to watch it again, and for those who were not able to join us today, hopefully you'll be able to watch it over the weekend sometime before our next webinar. So this formally closes our webinar for this week. Sana po ay makita-kita po tayo ulit next week. Same time, same channel from Friday, 12 noon to 2 p.m. It's a date.
Together, we can stop COVID deaths.
So keep safe, keep healthy, and see you online.
The enemy remains unseen. I'll keep your hand in mine. Let's say a prayer one more time. I know you long for home, but I am here, you're not alone. I'll stay with you until the coast is clear. The other's pain before my fears, the other's loves before my tears. But right behind the mask, I look into myself and ask, do I have strength to carry on? My God, how long must this go on? I need you here to keep me strong. I'm here to hold the line. I'll keep my word until my time. Just look into my eyes and say his name to realize it's fine to be afraid. Just hold on to the word he gave. This time will come to pass, 'cause this salvation's made to last. He'll carry you to see the break of day. The other's pain before my fears, the other's vows before my tears. But right behind the mask, I look into myself and ask, do I have strength to carry on? My God, how long must this go on? I need you here to keep me strong. I'm here to hold the line. I'll keep my word until my time. The other's pain before my fears, the other's loves before my tears. But right behind the mask, I look into myself and ask, do I have strength to carry on? My God, how long must this go on? I need you here to keep me strong. I'll keep my word, your word is mine. The other's pain before my fears, I'm pushing on despite the tears. Please take us through another day. Just hold my hand, I will hold the line. I will hold the